Good afternoon. This is Henrietta Awo-Oseanto, a Senior Program Officer at the National Academy of Medicine. Welcome to the first webinar in the Improving Care for High-Need Patients webinar series. This webinar series is an extension of the landmark National Academy of Medicine special publication, Effective Care for High-Need Patients, Opportunities for Improving Outcomes, Value, and Health. The special publication and the webinar series are produced in partnership with the Peterson Center on Healthcare. This series will highlight successful implementation of effective models of care for high-need patients from around the nation. On today's webinar, we will hear about the OneCare program designed by MassHealth and its implementation by the Commonwealth Care Alliance. Before we continue, I just wanted to note a few housekeeping items. Please type in your questions anytime during the presentation in the box in the bottom right corner on your screens. The speakers will be answering questions at the end of the presentation. Also, the slides will be available on the NAM HighNeeds Patients website after the presentation. I will now turn it over to Dr. Michael McGinnis, Executive Director of the National Academy of Medicine Leadership Consortium for a Value and Science-Driven Health System and Senior Scholar at the NAM, to provide an overview of the special publication.
Thank you very much, Henrietta, and welcome and thanks to all who've joined. I've got a couple things I'd like to emphasize at the outset. First, thanks not only to Henrietta, but to Melinda and Lori and John, who are going to be speaking and are engaged in some very important activities in Massachusetts that will help underscore the importance of the work that we're discussing today. And clearly I want to thank as well the Peterson Center for Healthcare and the Peterson Foundation, which made this work possible. Secondly, I want to just hit on the 3 points that I'd like to have you all take home from my comments. First is the important nature of the issue. Second is the partnership nature. And third is the stratification as in many ways, the key take-home lesson for the work that we're considering. On the first count, we know this is important from almost every perspective, financially, socially, its potential to impact across the healthcare delivery scene. Financially, it's well understood by now that only 5% of the patients who make up the patient arena have high needs and complex conditions that classify them as high need, but they together account for about 50% of the health spend. From a social dimension, there are few categories of patients whose circumstances are more strained and who require special attention from society in order to bring them out from the margins into mainstream care. And thirdly, the kinds of interventions that that we undertake to address effectively the needs of these patients can have a ripple effect, a salutary ripple effect for patients across the board. The partnership nature of this enterprise is also very important to underscore. As you see here in the slide, Peterson is in the middle for a good reason, because they were the group that pulled us all together. And who all of us is the National Academy of Medicine, which Henrietta and I represent, the Commonwealth Fund, from New York, the Bipartisan Policy Center here in Washington, and the Harvard School of Public Health. The 5 of us as organizations, along with our colleagues from other elements of leadership in this arena, worked over the time of the project and continue to work to explore extensively the literature base and the insights and experience of programs throughout the country to come up with the report. We had a superb planning committee, fully partnered in the effort, and you see them listed here. I'm not going to mention them, just to underscore that you'll recognize a lot of them as you look down the list. Thirdly, the importance of stratification as a key take-home is in many ways the linchpin lesson. Just to run quickly over the process, we held 3 workshops. They were focused on the who, the what, and the how of these issues. In addition, we convened 2 work groups, one to focus on taxonomy, because if you're going to engage stratification seriously, you have to have a good taxonomy, and the second on policy to begin the process of identifying concrete ways to engage the kinds of changes necessary in the policy arena. The characteristics of high-need patients, important to underscore that these are clearly not patients who fall into a monolithic category. They have multiple and variable characteristics related to the cost that they drive, related to the intensity of the care that they need, related to their functional limitations. And so the process of effectively engaging them requires full understanding of those characteristics. That's why one of the first efforts of the author group and the project and the focus of the meetings was on developing a conceptual model. And you see here the conceptual model for starter taxonomy for high-need patients. You see that there are 6 categories, and they're organized moving left to right by age. Children with complex needs, non-elderly disabled, those with multiple chronic conditions, those with major complex chronic conditions, the frail elderly, and those with advanced illness. We're going to talk today, as you'll hear from the OneCare folks, in particular about the categories of major complex chronic conditions and the frail elderly. The model also looked not only at the importance of these individual patient categories, but about the importance in a cross-cutting fashion for each of the categories of accommodating the behavioral risk factors that they experience and the social risk factors to which are important shapers of their health fates. Moving to the last slide that I'm going to present is a brief summary of the kinds of features that are characteristic of care models that deliver. And just to highlight the major elements, the 8 major elements that the author group put into the publication, they are teamwork, coordination, responsiveness, that is 24/7 availability when needed, feedback, medication management, outreach, the assurance of a seamless interface between the community and home, which relates to the next feature, integration of social services and medical care services, and follow-up. It's in many ways an all-hands-on-deck approach to these patients, and ultimately it's an approach that saves money as well as improves the prospects for the health that they deserve and the health that they need if society is going to be both humane and financially sound in its initiatives to help high-need patients. So let me thank you again for joining us, and thanks again to our colleagues in Massachusetts.
Thank you, Michael. We'll move on to today's featured model, which is the OneCare program, and we will turn it over now to Melinda Elwood, who is a health programs analyst, policy analyst, with Mass Health.
Great. Thank you so much, everybody, for having us. We really appreciate the opportunity to be here with you today and talk a little bit about our OneCare demonstration. So we can move on to the first slide. So OneCare is a state-federal demonstration targeting the non-elderly disabled, so folks who are ages 21 to 64, who are eligible for both Mass Health and Medicare, meaning these are our dual eligible populations, which I know the NAM report talks about a little bit. And our goal behind this demonstration, and for folks who don't know, a demonstration meant that we sought special authority from CMS so that we could implement this program. And essentially the goal was to have a single program that allows folks who are dual eligible to get all of their Medicare and their Medicaid services through a single integrated health plan. So as opposed to having a fee-for-service model where they have a Medicare card and a Medicaid card and a Part D card, they're going to get all of their care through a single health plan. And so CCA, Commonwealth Care Alliance, who you'll hear from later today, is one of our health plans participating in this demonstration. Next slide. So the goals of OneCare, I think, are, very similar to all of those that are undermining NAM's work in this very important area, and I think these will be familiar to many of you out there. So again, looking at trying to improve health and functional outcomes, understanding that this was a population who really existed in an environment prone to fragmentation of care. And the idea was really to also address cost shifting, which is specific to kind of the dynamic between Medicare and Medicaid for this population, and to target some of the unsustainable cost increases that arose as a result. And so essentially what it came down to was that we had this population of younger dual eligibles, again, under age 65, with very complex care needs, who at the time that we came up with this demonstration did not have access to any integrated care options. And so the demo began in January of 2014. Next slide. So as I mentioned, the idea behind OneCare is that it covers all Medicare services, so that includes hospital, primary care, all Part A, Part B, and prescription drug services, as well as our Medicaid services, which really in a dual eligible population, that means we're covering the long-term services and supports. And I think one of the things that NAM mentions in their report, which we also found to be really important, was that this demonstration allowed us to give our participating plans like CCA the ability to add additional services that wouldn't ordinarily be covered for a fee-for-service population. So things like additional behavioral health diversionary services, more flexibility with regard to community support services. So again, the ability to cover things like peers, community health workers, and other kinds of interventions that CCA has very creatively developed and that our other plans are developing as well. Next slide. So the populations being served in OneCare, again, I think this is familiar to the folks who have been reading, and following along with NAM in this project. And I think, again, we sort of use this umbrella of adults with physical disabilities, but as you can see, and as Michael emphasized, you can't really segment this population into one group or another. These are all folks with very much overlapping needs. So many of these folks are adults with serious mental illness, in addition to substance use disorders or having other multiple chronic illnesses or functional and cognitive limitations. And I would say if there's one thing that we've really seen with this population in particular is that there is definitely a lot of folks with high behavioral health needs. Next slide. So I want to emphasize something else that was really important to us in developing this care model, which was the importance of our stakeholders. I know we were introduced at the beginning, and Henrietta mentioned that this was something Mass Health had developed, but I really want to emphasize that this was something we developed not only with CMS, but really with a broad range of stakeholders, which we think is so crucial to developing these new models of care if they are to be successful. So we worked really hard and over a period of years to work with our stakeholders, including our consumers, our advocacy groups, our community-based organizations, and our health plans and our payers to identify the gaps in services and care coordination, to build a care model that really focused on enabling individuals with disabilities to live independently, and to ensure care is person-centered, and that it's members' goals that are driving their services and sort of their participation in the plan. We also have an implementation council, which is ongoing and meets on a monthly basis, and the requirement there is that this body is majority consumer members along with other stakeholders. Next slide. So again, I want to emphasize that the goal of our model was really to provide person-centered care and something that was really critical to our stakeholders. And I just want to emphasize here, I think these are concepts that are familiar to us all, but really the key things here are self-determination, respect, dignity. Our stakeholders really emphasize the importance, for example, of cultural competency and member choice. Next slide. So in terms of how the care model works, the OneCare plans, and I know CCA is going to get into a lot more detail about this, the idea is that care is delivered through a care team and a provider network. There is full integration of primary care specialists, behavioral health, and LPSS, and the whole care model is driven by the member, and the member is at the center of the care team of the whole process. And so when members begin, they do a care assessment, and then they work with their plans and their providers to create a care plan moving forward. Next slide. One unique facet of OneCare that was also important to our stakeholders was that all members be given the option to have something called a long-term supports coordinator. So all of our health plans are required to contract with an outside community-based organization, which could be a recovery learning center, it could be an ASAP, other kinds of nonprofit community-based groups that provide a person whose job is really to help the member understand and advocate for whatever needs that they have to help them live within the community and be successful. Next slide. Again, I mentioned the personal care plan. I think CCA is going to get into sort of how that is developed in conjunction with the member, again, with the member at the center of that process. Next slide. One of the things I also want to emphasize, and something that we built into our program, is I think we really need to be mindful of the fact that in many cases, when we're talking about this population and creating these new models of care, we're not working in a vacuum where members didn't have anything before. In many cases, whether it's fee-for-service or something else, we're talking about a population that's moving from one thing into this new thing, into this new model of care that we are creating. So when we created OneCare, we were really conscious of that transition, and we built in a number of member protections sort of around that concept. So for example, folks are always able to appeal any decisions that are made. We have a 90-day, what we refer to as a continuity of care period, where they can continue to see providers they were seeing prior to joining OneCare, even if those providers are not in the OneCare network. So a variety of protections to sort of maintain that understanding and to allow for that transition. Next slide. So some general lessons learned. As I mentioned, we began in 2014, and I know that CCA is going to get into a lot of details here, so I'm not going to spend a whole bunch of time, but we do have some key points that I want to emphasize. I think the first is that the care model really has to be flexible enough so that it can be adapted to meet the individual needs of members. I think, with OneCare, we really tried to create a framework, but it is our plans, CCA and also Tufts, who are implementing this and who can adapt that model, and with the understanding that members have many different needs. I talked about the sort of overlap between members who have one disability, but also a behavioral health issue and so forth. So it is really important because the care model, even though it is a general framework, works differently for each individual person. We also noticed that plans had to develop creative strategies to engage members where they are. So in this case, I've put the example up there of being unable to connect with members through traditional means. So for example, members who aren't responsive to phone calls or attempts at contact, and these could be homeless members. And I know CCA has done a lot of creative work that they'll probably talk about in terms of really trying to engage members where they're at. I also want to emphasize the importance of building the infrastructure to support the care model, and that this can take time and resources. So if we're building a new care model, it's important that whatever tools our providers and plans are using are designed to create that, to support that care model. So in the case of OneCare, all of our plans have a centralized enrollee record. They needed to figure out how to share data among all the care team members as appropriate, and they needed to build infrastructure to be able to track assessments, track care plans and service authorizations, and sort of the updates that go along with that, and then ultimately to be able to look at this from a population health perspective. For OneCare as well, and I think as we look at these models as being part of this movement towards social determinants of health as a key factor, it's been very important for our plans to develop relationships with community-based organizations. I mentioned that they have to have their long-term supports coordinators come from those organizations, and it takes time to establish those roles, to have those CBOs, for example, adapt to traditional billing practices in the medical world, and to develop trust. Workforce development and capacity is something that I think is also really important. So when we think about using care managers or using community health workers, ensuring that we are making efforts simultaneously to build up that workforce so that those folks are available and so that we can contract and work with them. In terms of evaluation, I think we could go through a whole other webinar on that, the importance of that, and I know NAM emphasizes this as well. But one of the things that we have learned is how critical it is to manage your quality and encounter data reporting at the plan and provider level to ensure that you have consistent data that accurately captures experience that can be used to really evaluate the efficacy of whatever model you're using. And finally, and we can't emphasize this enough, it is just crucial to have the stakeholder collaboration and communication, and I think that's important for a number of reasons. I think initially as we work with these communities, we really need to create buy-in and maintain trust among these folks so that they do feel like this is something that they are a part of, that they want to participate in, and again, that this concept of member-centeredness and person-centeredness is in fact a reality for them. It's also important to continue communications to ensure ongoing accessibility. I talked about how we're working with a population of members with disabilities, so accessibility is really key on a number of levels, linguistically, culturally, but also just physically, having places where folks can go to get the care that they need in the most effective way, and ultimately to get their input around ensuring that the care model is effective and to inform successful practice transformation. Next slide. I think that's about it. So I really, again, appreciate the opportunity to provide you with an overview, and now I'm going to turn it over to Lori Tischler with CCA, and she can tell you how CCA really makes this model work in practice. So thank you very much.
Thank you so much, Melinda. I'm delighted to be here with all of you today and to be able to talk with you about what we do and what the state of Massachusetts and our patients and members and care partners have made possible. So let me just start by telling you a little bit about CCA, which is Commonwealth Care Alliance. We're based in Massachusetts. We're a nonprofit community-based healthcare organization. We have, at this time, we're very proud actually to have over 25,000 members, all but probably 500 of whom are dual eligible. And about 2/3 of them are in the OneCare program. Our goal is to provide the best possible individually tailored care to our members and our patients, and we have done that and become nationally recognized for an innovative model of care, which I'm going to describe to you with the next slide. So CCA's care model, let me just start out by telling you guys that I am a primary care physician and practiced for a long, long time, taking care of many dual eligible patients and many people like our OneCare patients. And it was always a challenge as a physician to feel like there was so much I wanted to be able to do for my patients that I didn't know how to do, that I couldn't access, that I didn't that I just couldn't make happen for them. And my desire to continue to care for vulnerable people and to be able to be part of a changing system were what brought me to CCA. So for every patient at CCA, every member, they have a person. Every single one of our 25,000 members has a care partner. Those care partners may be nurse practitioners who go out to their homes, or they may be nurses, RNs, who meet with them on the telephone. In some cases, especially for our OneCare members who have many behavioral health challenges, often their care partner is a behavioral health clinician, a licensed independent social worker, or a psychologist. In some cases where the needs for our members are primarily social, we employ community health workers, which we call health outreach workers. And every single one of our members gets an individualized assessment and a care plan that helps determine what their needs are. And many times we will focus on their social determinants of health before we focus on their medical determinants. I have a member who I care for that I had all kinds of plans for what I wanted to do for her medically, and her care partner said, absolutely, but we have to make sure that she doesn't get evicted before you dicker with her blood pressure. And the truth is that those are the important things for our members. So in addition to the teams, to the individual care partner, we have teams that support the care partner and the member. So if somebody needs a new wheelchair, we might send a physical therapist out to their house to help measure them and help decide what kind of wheelchair would be better or best for them. For someone who is struggling with addiction but can't leave her home, we might send a substance abuse counselor out to her house. We coordinate care across the continuum, and that includes finding people. So that was something that Melinda mentioned, and I think, as you can imagine, anyone who is under 65 who's eligible for both Medicare and Medicaid has a complicated life. Physical illness, mental illness, high rates of homelessness, probably 7 to 10% in our membership. And that's a hard thing to count, so we suspect it's higher. So how do we even find these members who may get assigned to us through passive enrollment? And in our organization, we've developed a team called our Clinical Engagement Team. And they are a group of people who spend time both on the computer and on the telephone, but they also spend shoe leather going out to find patients, finding out that someone who's been previously unreachable is in the hospital and going to make a visit while they're there. I think my favorite story about that is a patient who was in the hospital and was homeless, and the clinical engagement team went out, and the patient was really upset because he didn't have his stuff. He'd gotten picked up by an ambulance, and the bags of stuff that, you know, he lived out of had been left under the bridge where he was living. And 2 days later, there was a note in our medical record that the care partner had found his stuff and brought it to him at the hospital. And that is the kind of work we do on the ground to engage people as individuals. Can I tell you that that person's metrics and HEDIS criteria is perfect? Of course not. But at least he calls us now, and that gives us a chance. In following with Mass Health's desire to ensure that we are respecting the members' voice, we also try to be as person-centered as possible. We've actually just started a new group within CCA, really looking at consumer-centered quality and ensuring that our members' voice is heard in everything we do and every decision that we make. Additionally, we think a lot about something here which we call dignity of risk. And the dignity of risk means that we respect our patients when they make decisions that may not be the decisions that we would make for them. This, as many of you know who are healthcare providers, is extremely hard for doctors and nurses because we want to help somebody get better and we don't want to see them make bad choices. And yet at the same time, if they're competent, we need to honor that. And at CCA, we honor that and we still take care of them. And that is a huge part of what we do. In addition, we provide care in the community for the member. 90% of our care is given in the home, though we do have 4 clinics. And then we have our ready resource teams, which are sort of urgent and emergent care, speaking to Melinda's 24/7, mobile integrated health, and crisis support units that John will speak to shortly. So another thing that we did, and actually if we can go to the next slide, another thing that we did when we thought about our OneCare members is we knew that many of our OneCare members already had places that they considered their medical or behavioral health homes. So we partnered with a number of community-based providers, many behavioral health organizations, but also some community health centers, where our members already had long-standing relationships, care partners, teams that they trusted, and we assigned care management responsibilities to those health homes. And that has been a tremendously successful program for us. So I guess, you know, one thing that we might say is that the only thing we can be sure of is that we have to be creative and that we have to tailor care management models to the patients. People who are chronically homeless may have very different care needs than someone who's a OneCare member who lives in a group home because they have cognitive or physical developmental disabilities. On this same slide, just a brief word about our Senior Care Options program, and that's our duals who are over the age of 65. The programs operate very similarly, but the reality is that the OneCare population is more complicated. Their lives are more complicated. They're much more transient, and we've had to be much more creative about bringing care to them and about having a really good partnership with the state as we thought about rates and what we needed from the state and what we needed from our care partners. And I was joking before the conference went on with Michael that Melinda, John, and I sit across the Boston Common from each other. But the fact that we sit across the Boston Common from each other allows us to have ongoing conversations about how to make this work, because we all want to make it work and we all know that it's complicated. Next slide, please. So this is just briefly to show you that while we have 18,000 members enrolled in OneCare right now, the number of people eligible in our state is huge. It's 139,000, and this is a small state. So I realize some of you are from New York, where half of Brooklyn is on Medicaid, but this really tells us that there is a need for programs that can take holistic care of people, can hear their voice, and can be part of things. Next slide. And, you know, I think one of the biggest questions for us, and whenever I go out to talk about OneCare or our senior care program, is, does it work? So yeah, it works. Takes some time, but it works. Our average OneCare member is about 50, and their average cost is 10 times the amount that we pay, that the average population pays for care. 76% of our OneCare members have a serious mental illness. That includes substance use disorders, and many people, as you're well aware, have both. 60% of them have 4 or more chronic conditions, and at least 4.5% of them are homeless, and many more are marginally housed. What we are seeing in terms of results is that it probably takes close to 18 months, we'd like it obviously to be faster, to bend the cost curve. But we're starting to see decreases in costs, decreases in hospital admissions, and these are huge successes. And I think the other thing that I want to say is that in an organization like ours, it has to be about everybody. This isn't just about the care partners who are patient-facing. If you come into our organization and come to new employee orientation, you'll hear the IT people talk about the fact that they are really happy to be setting up your computer because it lets you work on taking care of these members. So I think that sense of being mission-driven and deeply caring about patients extends throughout the organization, and I think that's really key to our success and our ability to do what we do. Next slide. So this is, I have to say, a favorite slide. As the patient said, I was always going from one doctor to the next, or I was going to the emergency room whenever my health got bad, which for these patients are all the time. I couldn't believe with CCA, they send people to your home to check up on you. They always have somebody looking out for you. And that's what we want to do. And at the same time, we want to help empower people within the limits of what they can do to also look out for themselves. And all of these zeros are pretty wonderful. It doesn't mean that people always take advantage. Many of our OneCare members, we're really working hard to get them to take better advantage of dental services and to work with programs, dentists that are willing and able to take care of our patients. the transportation to appointments is there, but the other thing that is such a great advantage of being in this kind of duals program is that we can also pay for some non-emergency transportation. So if a care partner thinks that it would really help someone to stay out of the hospital and stay sober, we can provide transportation to 12-step meetings. We can, on occasion, decide that going to church might help somebody's loneliness and keep them out of the emergency room. And maybe we'll send them to church one day a week. For patients who have been in the emergency room numerous times for chronic obstructive pulmonary disease or an asthma flare, we can authorize an air conditioner if that's the appropriate treatment. And the way that our folks work together on trying to come up with solutions that are not only member-centered, but safe and also cost-effective. Cost is probably not the first thing that the care partners will think about, but it's in there. And I was so proud of our care partners on a call last week as they were trying to decide how to safely come up with a system to provide backup power for a man who has quadriplegia, who can't get out of bed, whose home has frequent power outages. There were 5 or 6 people on that call figuring it out, and I think we've figured it out in a way that stays true to what we do at CCA, what the state and the federal government expect of us, and that provides equity for all of our members. It's a really exciting space to work in, and I am going to turn it over now to Dr. John Loughnane, who's our Chief Innovation Officer, to talk about some of the wonderful innovations that we have at CCA that really have made a difference in terms of our ability to take care of our members. Thank you so much.
And John, thank you, Lori.
Yes.
John, before you jump in, I just wanted to point out that we have about 10 minutes left.
Sure, and I will be succinct. So, Lori, thank you for that great overview. Next slide, please. So one of the things that occurred during our OneCare, both evaluation, planning, and then rollout, was identifying key areas that patients themselves told us during focus groups and other interactions that would make a difference in how they access care. And 2 main areas came into focus. And one was, in reality, patients did not want to go to the ER. They went to the ER because they had no other alternative. They had an issue that needed to be addressed, but they themselves realized if there was an alternative method to get that care that was both high quality, timely, and really connected them back to their primary care teams, they would be all in. And as part of that, we actually developed through our partner group, EaseCare, who's a paramedic ambulance company, a program that would absolutely meet those needs, and we called it Community Paramedicine. And the concept is that once a member calls us or an issue is identified by our primary care teams during the day, that a community paramedic would be able to go out to a patient's home and treat them in place. And we developed the interventions such as being able to place IV fluids, IV antibiotics, and other medications, being able to do basic metabolic panels and hematocrits and INRs in the patient's home with an iStat machine, and also being able to address patients' behavioral health needs or end-of-life needs or such with trained paramedics, a program that would ultimately basically allow the patient to be treated in the home if appropriate, or at times early identified that they need to go to the ER or the hospital to be admitted. So we've now run this program for over 3 years. We have over 2,000 runs. It is a pilot program that is under the Department of Public Health that at some point we hope will be promulgated across the entire state. But ultimately, what we saw from the members, we wanted to know what their needs were and to manage their expectations. Those were to be treated in a timely manner, at home if possible, with quality of care. And ultimately, we thought that with the concept of this care at home, we could avoid unnecessary ambulance trips by 911, we could avoid unnecessary ER care, and we know our patients get admitted at a higher level than the general population because of their complexity, unneeded futile hospitalizations. So next slide, please. We feel the program has been a real success, and what I want to talk about at this time is how patients feel about the program. We published a number of articles about this, which I invite you to investigate, but ultimately when we talk about our patients, does this meet those needs we identified? 95% agreed the visit was as good or better than an emergency room visit, 85% reported the visit averted a visit to an emergency room, and 93% reported the visit enabled to see a provider sooner. And that's what the program was supposed to do. But this was generated by the opportunity to care for these patients through the OneCare program. That is a key component to understand that our capitated rates that we get allow us this flexibility to align good quality care, financially efficient, and to meet patients' need in a way that we were unable to do in a fee-for-service type of structure. These numbers are a little bit old in the terms because we now have over 2,000 encounters, and our data looks exactly the same. And again, we wanted an enhanced member-provider relationship, and across the board, this has been a well-accepted program. Next slide, please. The other aspect of this is we saw that the savings that we kind of worked on, and we're still working on the final data on this, but we know that it costs basically $350 to go to the ED. We know it costs $1,200 roughly for an ED without admission. We know observation admissions are $2,600. We know the average cost of an inpatient admission is $12,000. Those of us who've worked in a lot of hospital situations know that so many of these admissions do not need to come in. If there was an alternative method to care for them, both the patient and the providers would be all on board. That's what the genesis of this program was. And we're showing this slide ultimately to show, if you analyze the problem and say, where are there some alignment where the financial aspect of what we do may not match what patients want and what we want to deliver as care, community paramedicine was a key area that we wanted to focus on. Next slide, please. The other aspect that we had talked about, too, was the idea of a CSU. And the crisis stabilization units were really set up to help patients who have behavioral health needs that could not be met in the community, but once they got to the ER, they were deemed not to have a more advanced care where perhaps there was a lockdown unit. And these were really key aspects of what we wanted to do. So we wanted to have patients who needed something more, that this just wasn't a 12-hour stay in an ER and then back home with follow-up care. So we developed these crisis stabilization units both at Carney Hospital here in the Boston area and a home in the Brighton area called Marie's Place, where ultimately we can provide patients who need more intensive behavioral health treatment but do not need an inpatient environment to basically transition back to a more successful aspect of what they're going to do in the community. And we have also found that program to be tremendously well accepted and to be engaged with patients on a regular basis so that it's a continuity of care. The same people they engage with our crisis stabilization units are the same people that they engage with further care as they move out. So again, these longitudinal relationships are a key component of our interventions. Thank you.
Thank you very much, John, Melinda, and Laurie, for your very insightful presentation on the OneCare program and its implementation at CCA. We do have quite a few questions that have come in, so I will start with the first one. And John, if you can start with, I'll start with you on this particular question. So can you explain the workforce needs, the workforce needed to take care of these 18,000 patients? And in your assessment, is this program scalable? And how many employees and costs, how many employees are required, and what is the cost associated to take care of the 139,000 dual eligibles that you had indicated earlier? I think that was in Laurie's presentation. So this is a multi-pronged question. So the workforce needs to take care of the 18K patients and whether the program is scalable. Maybe we can start with that.
Yeah, so and I'll invite Laurie to speak to this also. So number of key points. One is the workforce needs to be aligned to what the patient's needs are identified. You know, we have a saying here that patients have taught me since they been at CCA, which is nothing, about us without us. So the answer is at CCA, the workforce is a diverse, interdisciplinary, multi-focused team. So there may be some patients who need a workforce that's very much more focused on community health workers and less on pure medical care. There may be some individuals that really are in the in part of life who need a high level of medical touch. They need support, but it kind of goes in this idea of what I call a seesaw, where at times it may be one higher input on the social determinants part of what's happening. Sometimes it may be higher on the medical intervention. So I think the most important thing is to know your population, make an assessment of those needs, and match the workforce to basically deliver the care that's going to align with both patient expectations and ultimately their medical structure. Lori, do you want to speak to the other issues?
I mean, I think I agree with what John is saying. And is it scalable? I mean, certainly that's the question. We're still here, having scaled from about 2,000 members, what, John, about 6 years ago? Yes. Or a little more, to 25,000 members. There are definitely challenges in terms of growth, but it's really about finding the right people and figuring out what our patients need.
And I'll also add that the concept in the lesson is absolutely scalable, but as we know, almost all healthcare is local to some degree. It's the relationships that patients and providers, with the definition of providers very, very broad, develop. So I would invite you all to think about what we talked about today is how would you move this into your communities to serve 5,000, 10,000, 15,000, 50,000. So I think ultimately what we've actually presented is a framework, it's a blueprint, and the scalability is what will happen in the local structure.
And it's also a blueprint that works for us in our geography and in our sort of social and political milieu. It's going to be different everywhere, but I think that's kind of the challenge of it and the excitement of it. It's different for us the way things work in the western part of Massachusetts and the eastern part of Massachusetts. For example, around transportation, the distances are greater. There isn't much public transportation in the west. And if you're in the greater Boston area, distances are small, traffic is terrible, but there is public transportation.
Thank you, Lori. Sticking with costs, John, can you comment on the costs associated with the use of community paramedicine and the CSUs that you had mentioned?
Sure. And again, I apologize, there was one slide on the CSUs. So the first thing about community paramedics is we started this program in 2013, but community paramedicine, again, has basically moved across the country and looks very different from each locality, the locales. So I'll give some true advice on this one since I've lived this almost every day since then. One is the cost structure will be associated ultimately with two aspects. One is the community paramedics, and there's an upfront cost about training, there's an upfront cost about how you're going to take a vehicle and which resources you're going to put in to allow your paramedics to then perform whatever tasks they're accompanied to. There's also the medical direction. How much do you have to engage in supervising the paramedics once they're out in your patients and seeing what they do and how the interaction would be. The two parts about the finances are, that's going to look, again, very different in your community according to, one, what you want the paramedics to do, and two, how you're going to process how they interact with their normal 911 system or other aspects. So again, this is a blueprint of where we go. But what I will say with the finances and with community paramedicine is ultimately it's about the ROI and returns of savings. What's occurring with these programs is that ultimately you are diverting high-cost care to a more, what we feel is efficient and aligned environment. So when I put out those KPIs about how much it costs to put someone into an ambulance, how much it costs for the ER, how much it costs for the inpatient stay, whether it's ops and such, if you can disrupt that area, that's where ultimately the community paramedicine program returns. So it's an investment with the concept of getting a return on what you're doing that you need to follow. But again, that has to be clearly defined by what you are trying to get as your goal. Are you trying to get people to stay home for congestive heart failure, or are you trying to get people to stay home for a wide variety of different entities as we move on? The other aspect is when we look at the crisis stabilization units, what we have found over time here is that we have seen a 9% decrease in the number of days that CCA members have spent in psychiatric hospitals. So that's something that we're really proud of. We don't have specific figures on the presentation, but basically inpatient psychiatric beds are not inexpensive, and we've seen a substantial savings in that area. We also have high member satisfaction, 99%. Basically thought they were basically able to think that the community care structure we set up was really meeting their aligned needs. So again, I think that as you take these ideas and concepts, you define goals, and then you look into your environment and think, well, how much is this going to cost to design this outcome?
I think the other piece is that when we design programs, we think about the cost and the idea of ER diversion, but actually community paramedicine, when John and his team designed it, was not necessarily about ER diversion. It was about getting the right care to people at the right place. The fact that it diverts people from the ER is fantastic, but if I'm on call and the paramedic calls me and someone needs to go to the emergency room, that's what they need. But we can also get them to the emergency room. The paramedic follows them and gives report, and so that we are hoping, at least, that the use of the emergency room becomes then more efficient.
And I think Lori makes a good point. One of the other aspects that we're studying now with the community paramedicine program is earlier identification of patients that we can go out and see and say, you need to get to the ER and be hospitalized now. Does that impact ICU stays by early identification, because a patient doesn't wait until they feel really sick and then go to the ER? If we get this earlier because we're providing the right care at the right time, we move patients into the appropriate care structure earlier so they don't end up in the ICU for 12 days. They end up on a regular floor for 3 days for their congestive heart failure exacerbation. So again, I think Lori makes an excellent point. It is actually community paramedicine. In its essence, people think about ER diversion, but when I think about it in that sense, I think about it as a right pathway to the care that meets the patient's ultimate medical goals at that moment.
Okay. And in terms of meeting the patients where they are, when finding creative ways to find patients lost to follow-up, this question is really about the resource and sensitivity required in really reaching the patients where they are. So what's the cost and benefits associated with targeting patients, and how do you efficiently tailor these individual outreach efforts? Lori, do you want to start with that?
Sure, I'll take a stab at that. And I don't know if Melinda is there and may have a sense of, in a general sense from Mass Health, how people are able to do this. One of the things that we do, the clinical engagement team is not all clinicians. In fact, it's a lot of people who are Googling and calling numbers and using, whatever the electronic version of a reverse phone directory is to find people. Sometimes that's all we need to do. Sometimes engagement is as simple as using the systems that we already have in place for identifying people who have come into the hospital or the emergency room and then reaching out to them because all of a sudden we know where they are. They've learned things like if we're trying to call members, we call them at the beginning of the month because at the beginning of the month is when they have minutes on their phone. We've done a really interesting pilot program that's been very successful with Boston Healthcare for the Homeless. We gave people phones so that they could reach us. And one of my favorite quotes from a member who got a phone was, "I'm going to call my mother." I mean, it was basically that these phones were transformative for people in many ways in terms of their whole life, but they also allow us to find them. We send community health workers out when we're looking for them, in terms of the street team, and that is a pretty cost-effective professional degree. So we're able to use we're able to do it fairly efficiently and within the systems that we already have. We're not perfect. There are always going to be people we can't find or people who get lost to follow up. But our community health workers also will drive by people's houses and drop a flyer or knock on the door. It's a lot of work, but I would say the majority of it gets done in a much more efficient way than somebody pounding the streets.
Yeah, this is Melinda. I want to echo everything that Lori said, and of course our plan, CCA, they are the boots on the ground, so they are very much educating us on, the strategies that they've developed, as Lori mentioned, working with the community, working creatively with different workforce members to reach these members, essentially where they are at. And I would say it has been a challenge. One of the challenges, I think, of demonstrations, not just in Massachusetts, but across every state, has been around sort of how do you get to these members who are homeless, or oftentimes we may have address discrepancy data between what CMS has on the Medicare side and what we have on the Medicaid or Mass Health side. So I just want to echo that has been a challenge, but I think that our plans have really stepped up to the plate in using these creative strategies. I think the only other tool in the toolbox that I would mention is that we do have the benefit in some cases of claims data, and that can also be important in sort of illuminating, okay, this person may be homeless or we may not have a good address, but we know that they see Dr. X or that they've incurred claims at this place, so building partnerships at the provider level as well.
The other thing I would add to those excellent points is I also think once you start to engage patients, the word goes around, and I think that's an important element, that one satisfied patient member can help have others feel really good about contacting you. So at times I've had experiences where I've had a patient who really had some distrust of the medical system, have a good experience, and the next thing I knew is at the beginning of the program, they had talked to two of their friends and said, this is real, this is going to help you, and then they engaged. So I do think that understanding that there's an ecosystem of care that patients themselves share, and once you have the ability to impact one person's life, they'll tell others that they should do the same. And I think that's an element where peer-to-peer with our patients, understanding and saying this is good for you is a key element in allowing us to engage in a meaningful way.
Okay. We probably have time for 2 more questions, so I will switch to a couple questions that have come through specifically on the results that I believe Lori had presented on hospital admissions, on the impact of the model on hospital admissions. Can you elaborate a bit on the methodology for assessing that 7.5 fewer hospital admissions and the 22% fewer admissions in the 18-month period, and also discuss a bit as to how much of that was due to regression to the mean versus really how the methodology you use to assess the reduction?
I think it's a fantastic question. I think that whoever asked the question about regression to the mean, you're absolutely right. It's certainly possible that it is, and these are not fancy statistical calculations. It's really looking at how many hospitalizations did we have over these sort of rolling periods of time. What we are seeing is that these numbers are sustained, so I think that this has been a positive thing. I would be happy if the person who asked the question wants to send me an email, I would be happy to connect you with the people who actually did the analysis so I can get you some more detailed information.
Great. Thank you very much.
One other thing, though, I would say is that in a population like this, when you first start providing care for them, costs go up, so do hospitalizations go up. And I think you have to expect that, and we did, and we expect that every time we get a bolus of new members.
This is John. I want to really echo that. There's unmet needs, and ultimately, whether it's OneCare or SCO or just care in general, we're trying to do what's right and medically appropriate for patients. And often these are folks who have not engaged in the healthcare system, and especially the primary care system, in a very longitudinal way. So that's right, and I think that's such an important element, that the ability to have the program create relationships, to engage in patients, and then get the care model into what all this would be, we would accept as evidence-based care. That takes a while. So when I think about regression to the mean, I often think about what happens if I don't engage in these patients, and they actually have less coordinated care and ultimately have decline of their medical condition. So I think that's a difficult calculation, but I think it's an important element to understand.
Thank you very much. So we are just about 2 minutes from the top of the hour, and so I want to go ahead and thank all our featured speakers today, John, Melinda, and Lori, for your participation and your willingness to share your experience in Massachusetts, and also to thank everyone for joining this webinar. I wanted to, before we disconnect and get off this call, I wanted to encourage you to register for the next webinar in the series, which will be on March 29th, and we will feature Health Quality Partners, their advanced preventative care model, which targets elderly complex care patients. So you can register on the NAM HighNeeds patients website. The slides will also be available, the slides from this presentation will also be available on that same website, as well as the special publication that is also available on the HighNeeds website for download. Thank you again very much, and that's it for today.